and we'd like to welcome you to this week's briefing, a platform set up to facilitate weekly engagement with members of the media, providing updates on key health issues on the continent of Africa, particularly around outbreaks that are going on, the Mpox, cholera, Ebola, and many others that are happening across the continent. As usual, we have with us the technical team from the Incident Management Support Team. Today we have with us Professor Yap Bom II. He's the Deputy Head of the Incident Management Team based in the Democratic Republic of Congo. He's going to be sharing the latest insight and updates on what is happening in terms of health emergencies on the continent with us today. As usual, we have our language facility. Unfortunately, today there are many things happening, so we don't have interpretation for you, but we're going to share with you details from this section as you'll be following later. Let me now bring in Prof. Yap to begin our section. Over to you, Prof.
Thank you very much, Nick, and good morning, good afternoon, good evening to all of you, to the journalists, to our colleagues, and to all the collaborators that are in the field responding to all those different outbreaks that you've mentioned. As today we are dealing with Mpox, cholera, Ebola in DRC, Rift Valley in Senegal, and Mauritania, as I will show to you. But also to our leaders. Our Director General, John Kaseya, is currently in United States, in DC, to attend the World Bank meeting, while the Asian Manager, Dr. Ngashi, is currently leading our delegation for the Mashako on vaccination that is happening in Senegal. And this is after a very intense week at the World Health Summit in Berlin, just to highlight that we are quite a number of activity happening to moving forward, ensuring that we have a healthier and safer continent. Over to you, Nick. Thank you. I will start with welcoming you on behalf of Dr. John Kaseya, His Excellency, Director General of Africa CDC, for the 4th International Conference on Public Health in Africa that will take place between the 23rd and the 25th October in Durban in South Africa. So this is really the time where all the researchers, the scientists, the policymakers, the community healthcare workers, the ministers, and some head of state will convey to discuss on how we've been progressing on ensuring that we have a public health that is moving within these new public health orders. So we invite for all those that have not been able to complete their registration to do so that we can have this gathering starting next week. Next slide. So as mentioned, last week was quite an intense week, actually early this week, with the World Health Summit that took place in Germany, in Berlin. And one of the key breakout of these meetings really is the commitment of Germany of €1 billion to the Global Fund. So this is really a way to boost what we call the new public health orders, as Africa CDC and EU member states scale primary health care, surveillance, and of course, local manufacturing on one hand. On the other hand, it's really the opportunity to leverage this fund so that we can accelerate the progress that have been observed on HIV, TB, and malaria, because we've seen that in many countries, HIV is restarting to increase while we've been seeing a stabilization. So it's an opportunity to strengthen the prevention, the treatment access, especially after the decrease of the funding and the decrease, therefore, on availability of drugs in many countries, but also the lab network and the community system. It will also serve to build a more prepared and equitable continent by reinforcing the health workforce, the supply chain, and of course the sustainable financing, because we really want our countries, our member states, to have that domestic funding so that they are able to respond to outbreak, but also to move toward universal health coverage. Next slide. So following that, the investment on the Global Fund, there's also been that opportunity of having the G20 high-level panel on pandemic preparedness. As mentioned, we are dealing with quite a number of outbreaks as we do speak now, but we still need to improve in preparing the upcoming outbreak. And we don't want, as the continent, to be just a beneficiary. We want to be a co-architect of the global health security, driving the regional manufacturing, the pool procurement, the innovative funding to strengthen our health sovereignty. And we believe that the partnership with Pandemic Fund and others will really shape a fairer, more sustainable global financing system for pandemic preparedness. So the way we are seeing it, as far as the African continent is concerned, African institutions such as Africa CDC should really lead, while the multilateral organization should be supporting on fund mobilization, but other activity, including the health workforce and others. Next slide. Specifically on the HIV, hepatitis B, and syphilis, we really want to push and to have a champion for Africa where no child is born with any of the three diseases. And early this week, Maldives has been celebrated by the WHO for the achievement on reaching this critical milestone. So we believe that with the right tool and leadership, as it has happened in other countries, like I just mentioned, Maldives, Africa can also achieve that triple elimination. So that will include antenatal screening and treatment, birth dose HPV vaccination, syphilis testing and penicillin, and of course, strong surveillance. So through the African Elimination and of Vertical Transmission Initiative, Africa CDC, together with the AU member state, will be strengthening the primary health care, the laboratory, and the community partnership. And you've seen that those three keep on coming on and on in a different partnership, in a different partnership that we are signing. Next slide. For the pandemic resilience, we are really seeing together with our Ministry of Health, here we can see the Minister of Sierra Leone, Dr. Honorable Dembi, how in that panel, we really want to push beyond the response toward the resilience, how we build that strong regional cooperation and investment. And the incident management support team, especially in Sierra Leone, has played a key role. That coordination played a significant role on shaping the way they've been responding to Mpox. As you will see in the slide, we speak less and less about Sierra Leone, while you remember that at one point of time, it was really one of the most concerning countries. This is also an example on how we build that resilience. And also to affirm that African leadership and ownership are advancing the new public health orders and strengthening our collective health security, because we are all interdependent. Next slide. The digital sovereignty, Africa's data-driven health future. This is really one of the key pillars, one of the key challenges that we want to address. And this was really at the heart of some of the discussion in Berlin, to ensure that we digitalize primary healthcare to our own data. As we mentioned some time back here, we have this partnership where we are leveraging the DHES2, which is a tool that is used in many of our countries to gather data. So the idea is to add on top of that a tracker that will allow during outbreak, as we've done with Mpox, cholera, currently doing in Ebola in DRC, so that we can collect data in a real-time basis. So having those tools used at the level of the continent, across the continent, will help us to move forward, having a continental database where every country will be able to access in a very secure manner their data, but also we can have a common way of use evidence for decision making. So this is really connected to our investment in homegrown innovation and governance, because those ameliorations are really coming from the field, from our leaders who really want at any point of time to know what is the status of their countries. So this is where we are moving, and we consider that this digital ownership is really a matter of sovereignty of our member state. Next slide. Now, coming back to the different events that we are seeing in the continent, Mpox still leading in terms of number of states with 26. Cholera, which is leading in the number of deaths. You can see we have 6,437 deaths due to cholera in 2025. We have measles across 20 countries, dengue, Lassa fever in 4 countries as we do speak now. When you look at the total moderate and high risk event, you can really see that comparing to 2024, we have a significant increase in the number of events, especially the moderate risk, showing that we have almost every week different events that are happening in our continent. And this reinforces and strengthens all what was mentioned before, the need for the continent to strengthen the resilience, the preparedness, so that we are in a position to respond to all those different outbreaks that occur at the same time, as I will be showing you later. Next slide. Starting with Ebola virus disease in Democratic Republic of Congo. So we are glad to say that the outbreak still is contained in the Bulape Health Zone in the Kaseya province. So far, we've been having 53 confirmed cases, 34 deaths, which make a case fatality ratio of 64.2%. One health zone only has been affected. 337 samples has been tested so far. And what is important to note is one, the contact listed, the contact follow-up are quite impressive. The contact ratio is 1 to 32, while we usually target an average of 1 to 20. So this is quite significant in emphasizing the good surveillance that is happening, and that has to continue until we declare the outbreak ends. The bed occupancy has also decreased to 35%, and what is important to highlight right now is the vaccination. 27,000 doses has been deployed in DRC and moving to Bulape, and so far 22,000 people has been vaccinated, which 291 are frontline workers. Remember that 4 healthcare workers passed away in the early phase of the outbreak. So this vaccination of frontline workers, which is happening in Bulape, should also be happening not only in Bulape, but in all the health zone, in all the provinces that are at risk of Ebola. So the mapping that has been done and the plan that the DRC have developed should be now being operationalized so that we can protect the health workers, the frontline workers in those areas. Because just imagine that if the 4 colleagues that passed away had been vaccinated before, then they would have not passed away. And this is not only talking about DRC. For all the countries, Angola, others, there is an opportunity to do what we call preventive vaccination for Ebola. There are 500,000 doses of vaccine that are available at the ICG for this preventive vaccination, just to emphasize that the global partners are ready to support to prevent this Ebola to occur in many other countries. So now we are quite glad to see that we've not had any confirmed case for the last 16 days. Next slide. From Ebola virus disease, we move to Rift Valley fever, moving from the Central Africa to the West Africa in Senegal, where currently we had 20 deaths, 171 confirmed cases, and 827 samples has been tested. So the affected area are those 5 regions of Saint-Louis with 54.3%, Louga, and then Matam. What is also important, and that has been highlighted last week, is that this is a zoonotic disease. You see that we have on one side the animal that have been affected, and we see 22 cases and no death, but we can see that 452 abortions have been reported. So which means that those animals have been affected, leading to an economic impact on top of the impact in the human. So far, 11,000 animals has been vaccinated, and the installation of mobile lab in Matam Regional Hospital, it's also an opportunity to get closer to the hotspot and ensure that the testing is happening in a timely manner and ensure that we can actually control the outbreak at its source. Next slide. Moving from Senegal to Mauritania, we see that in Mauritania, we currently have 13 deaths. Out of 36 confirmed cases, they have 106 suspected cases. And you can see that this week we have a decrease in the suspected case, but we have an increase by 2 of the number of confirmed cases from 17 to 19, with a decrease in the number of deaths from 9 to 4. So in Mauritania, the hotspot are Brakna with 30.5%, Trarza, Nouakchott, which is the capital city, Asaba, and Gidimaga. So far, the vaccination has not been able to be implemented. The cases are treated in regional hospital facilities, and some facilities are already equipped with the initial batch of medication so that we can really take care of the suspected case when they arrive. Because with a case fatality ratio of around 36.1%, it is quite high. So we need to make sure that the team are in place, they are trained, they have the PPE, and they also have what is needed to take care of the patients that are coming through. Next slide. Coming to Mpox, we can say that as you can see in the graph, there is a continuous decrease in the number of suspected cases from 2,264 to 1,936, but also by the confirmed case almost by 50% from 603 to 328. And what you see also when you compare the 2 year 2024 and 2025, you can see that right now in terms of suspected case, we are around 150% as compared to the last year. But in terms of confirmed case, it's 179%. While in terms of death, it's definitely the much higher, 507% death as compared to 2024. So it's still real, it's a huge impact, but we are glad to see that the cases are declining in terms of average by 78%, but also that you keep on seeing the improvement, especially testing coverage, which is more and more reassuring on the surveillance, but also on the opportunity to use the Mpox as a way to strengthen the health system. Because when the testing coverage is increasing, it's also an evidence that the laboratory are getting closer to the community and that the capacity to bring the sample from the community to the lab is also improving. So if it's improving for Mpox, as you will see in Burundi, it will also be used to respond to other outbreaks. Next slide. Now, when we look at the change in Mpox confirmed case in the top countries, we can see that the countries that are the most of concern currently, not only by the percentage of increase, where we see Kenya, Malawi, Liberia, and Ghana, but when we look also at the magnitude, the number of cases in those countries, definitely Kenya, Liberia, and Ghana are the countries that are the most concerned, as you can see the burden. Next slide. So talking about Kenya, we are glad to see that there is an improvement in the surveillance. If you see the test positivity rate has decreased from 73% to 36%, which means that the cases are actually found in the community rather than having those cases found in the late stage at the level of the hospital. So far, Kenya has confirmed 659 cases, 10 deaths with a case fatality ratio of 1.5%. And so far, 28 out of 47 county has been affected. Now, The challenge is that initially we were really dealing with the case in the coastal, Mombasa, Busia, and you can see now that for the last few weeks, Nairobi is really among the top 3 cities that has been affected by Mpox, which is quite challenging in terms of the dynamic of Mpox when it reached a capital city. So the 3 account for 67% of the total confirmed case, and we can see that only 3% of the contact tested positive for Mpox, which means, once again, we keep on repeating that with that sexual transmission of Mpox, the contact, the usual one that we are identifying at home, are not the key one. The key one are those who are part of the sexual network. And with the challenge of stigmatization, it makes it very difficult to get those right contacts. That's why we are supporting the country to find ways like geolocalization help to allow us to actually track and identify the right contact, and therefore make available the vaccination. As you can see, 10,000 doses of vaccine has been used in the country, and then now we are in supporting the country to make available 20,000 more doses to ensure that they can also contain the outbreak in Nairobi amongst the hotspots that we are seeing currently. Next slide. In Liberia, we keep on seeing an increase, though this week we gladly see the decrease in the number of suspected cases, but also confirmed cases. And here you can see that the test positivity rate is around 52%, which is not bad, but need to be working on, which means we need to support more the colleagues from Liberia. We did have last week the intra-action review. And during that time, they really paused and agree that the most challenging part of the response is, 1, to improve on the coordination, 2, to improve on the surveillance, to ensure that the surveillance is really active, happening in the community, in those counties of MODERATOR that account for 69% of all confirmed cases. This is really where the active surveillance need to happen in the household by household, because you also see that 75% of the active cases are isolated at home, which also highlight what was discussed last week, the need to strengthen the care at hospital, in healthcare facility, by providing not only the adequate care as they started, but also provide what is around the medical care, talking about the holistic care, the mental health, but also the food, so that patients who are suffering from Mpox don't have to go out to look for food, or they don't have to have the relative coming in and out with the risk of spreading the disease. So far, 20,000 doses of vaccine has been deployed, and we are supporting the country to ensure that the vaccination are happening, targeting the right population. Next slide. Now, looking at Ghana, we continue to see the increase in the number of suspected cases, as you see, from 69 to 216. The number of confirmed cases as well, moving by almost 74%, by 38 to 66. So far, the country has declared 3 confirmed deaths with a case fatality ratio of 0.4% out of the 692 confirmed cases. Now, the challenge in Ghana is still around the active surveillance. You see the test positivity rate is around 51%, while we expect it to be around 30%. So it's critical to go in the community, which requires some support, some fund, as we know. But this has to happen really in those hotspots, because we see that 77% of confirmed cases are really concentrated in the greater and Western Accra. So that's where all the effort has to be implemented. And secondly, the surveillance. You can see that only 2.5% of the contact became confirmed case, but also we can see that for one case, we have only 4 contacts. While remember, when we're talking about Ebola, we are talking about 20 contacts that are expected for each case. So this is a big challenge on the surveillance, on getting sure that we have access to the right contact, we can follow them, and then we can make available the vaccine in those right population, because the country has received 33,000 doses of vaccine, and then there are 7,000 doses that are still awaited. Next slide. Talking about vaccination, we are gladly to announce that Malawi has actually rolled out the Mpox vaccination. You can see some population that will happily show the vaccination card, which again emphasize the appetite for vaccine in those countries, because at some point there was some concern about the vaccine hesitancy, which we are not seeing in most of the country, if not all the countries where we are implementing the vaccination. Rather, the challenge will be, one, the ability of vaccine, or two, the availability of operational costs that are the funds that are needed for the vaccine to leave the warehouse and to get to the patient. As we do speak now, we have 68,000 doses of vaccine that are either procured or donated. So we have some engagement with the country, Cameroon, Senegal, and other countries that might need to receive those vaccines. Maybe the challenge it is highlighted here is that none of those doses come with operational funding. So it's really a big challenge, especially in countries which definitely have not planned to have this outbreak and therefore may not have in their budget line the funding for those vaccinations, though they appreciate that it is critical. So it's also one of the key discussions that we'll have next week in CEFIA in Durban is how do we reshape, how do we rethink the way we support countries in terms of those operational funds, but also in terms of themselves having those epidemic funds through the domestic funding, allowing them to have what is needed to protect their population. And UNICEF still have at the level of Bavarian Nordic 2,666, 210 those that are available if the money is found to pay for those vaccines and also the money found to support the country to implement the vaccination. Next slide. Now, moving to cholera. The comparison that we will make today is to see what has happened within 3 years. In 2022, we were having 104,000 dose case across 15 countries. You can see 2,375 deaths. And 3 years later, while 2025 years is not yet over, you can see that the total number of cases has been multiplied by 2.8, and the number of deaths has been multiplied by almost 3. While the number of member states has increased by 7. So this is just to reemphasize the challenge, the exponential increase of cholera over the last 3 years. And this is due to many factors. There's not only one. We can name the climate change. We can name which lead to flooding, which is a key driver to cholera in many countries, as we will be seeing later, but also the humanitarian conflict, which is happening in the eastern part of DRC, which is affected by cholera, which is happening in Sudan, South Sudan, in Chad, quite a number of countries that are affected by both, actually. The climate, but also the humanitarian crisis that are really fuel for those outbreaks, which is also re-emphasized that response at the 3 level, the political level, where the head of state with our AU champion, the president of Zambia, pushing to the establishment of the national task force in each country so that we can ensure that we have a multi-sectorial approach. Because as you've seen, it's not only the Ministry of Health who can solve the issue of cholera, as we'll see later in the Angola. Next slide. Now, when we look at the top 3 countries that are really of concern, you can see that Chad continued to experience a sharp surge. We also have Angola that we at some point will really see a decrease, but we have a second wave. We'll come back to that. And we also have Burundi where we see an exponential increase by 238%. And then we still have countries that are stable like Sudan, but remain very high, though cases dropped by 50%, showing a progress, but with significant ongoing transmission. In terms of decline, we have South Sudan, we have DRC, we have Somalia, but of course we need to keep on, one, monitoring, but more importantly, find sustainable solution to address these outbreaks. Next slide. Now, specifically looking at Burundi, we can see that over the last 6 weeks, there has been some significant increase in the number of cases. This week, gladly, we can see a reduction of 15%. We have no death that has occurred with a case fatality ratio of 0.4 since the beginning of the outbreak. We've seen that has been reported. So the hotspot at northwestern Burundi were in the side of Cibitoke, Bukinyama district. The driver are the same: unsafe water, lack of proper latrine and water treatment, massive influx of refugees from neighboring DRC, and this highlight again what I was mentioning, the humanitarian crisis as a key driver. Now, in terms of intervention, Burundi is really leveraging on the great experience that they got during the Mpox with the surveillance at the community level, with the door-to-door hygiene awareness campaign, the disinfection, to ensure that at those levels and in the affected level village, they can also provide population the soap, the water that they need to have the clean environment that can. This is the key point to limit the cholera. But the challenge remains with inadequate water infrastructure in rural area and concurrent crisis, refugee influx, flood, that is straining the response. And this also, and once again, highlight the need for multi-sectorial solution to address this issue, because on one side we have the medical, but in the other side we have the infrastructure. Next slide. In Angola, we are seeing that second wave, we'll call it that wave, that has been coming up for the last 4 to 5 weeks, and you can see a 44% increase in the number of cases. We are now from 574 to 828, but also an increase in the number of deaths from 10 to 23. And you can see that we have cumulatively a case fatality ratio of 2.8%, while what is considered as a threshold is 1%. So we are really far beyond that. Now, the hotspots that are presented include Uyula, Yulje, Kunene, and Lunda. That is despite the vaccination that have occurred with 3.57 million people that have been vaccinated. The challenge that we are seeing here in Angola is the fact that vaccination has occurred as what we call a reactive vaccination, where one dose of vaccine is being distributed to the population, but despite that, the efficacy is not 100%, so that possibility of having some case occurring. But now also what we see, we have some new districts that are coming on board where vaccination has not occurred. So this is just to highlight, yes, it's great to have the vaccination and all the effort, but definitely a more sustainable solution is needed, and the driver remains the same. So definitely the country is really strengthening the response with the establishment of new cholera treatment center. Next slide. Now, to summarize, we have those 4 critical outbreaks that are occurring. The Ebola, where we gladly see that it's been contained with great support in terms of vaccination, but also surveillance, and the last case that occurred in the last 16 days. For the Rift Valley, we continue to spread between Senegal and Mauritania, and that underscores really the urgent need which is happening and which is really supporting the country, with whom we had some interaction yesterday on cross-border coordination and also the One Health approach, because you've seen that on one side we have the human dying, on the other side we also have all the livestock which is being affected. On Mpox, still, we keep on seeing the decrease in most of the countries, but we have those 3 to 4 countries, Kenya, Liberia, Ghana, and a bit of Guinea, that remain major concern. So as cholera is concerned, we see the rapid escalation in Chad, in Burundi, in Angola now is experiencing this second wave. So this is a great example that we should not rest until all the countries are really stopping the spread of those cholera outbreaks. So now I will hand over to Nick and be happy to take some questions for the journalist. Thank you.
Thank you for the comprehensive briefing, Prof. We will now proceed to the question and answer segment of this briefing. As usual, colleagues, you know how to send in your question. If you're just live with us on the call, you can raise your hand. You will be recognized. If you've already sent in your question to the Q&A, we will be picking from there to transmit to Prof for response. So today we'll start our Q&A section from the live section. We see our colleague Gabriela Emmanuel is on. She's from NPR. Gabriel, you have the floor.
Hi, thank you very much for doing this. I wanted to ask about the Ebola outbreak in the DRC. In particular, I'm interested in whether we know whether this is a spillover event or has been linked to a previous outbreak. And in relation to that, I'm interested in what is happening regarding kind of persistence of the virus, that it can remain in the body after somebody survives Ebola, and what the plan is if this outbreak does wrap up for monitoring those survivors going forward. Thank you very much.
Thank you, Gabriel. Prof, those are loaded questions. I'll give you the time to respond, then we take the second set. Over.
Yes, thank you so much, Gabriel, for this great question. So, first of all, if you remember, we were really happy to see that the sequencing of these viruses has been done within 24 hours by the team led by Dr. Placide Mbala from ENRB, showing us that actually it's a new spillover. And the virus that was identified through sequencing was more related to the virus that was discovered in 1976. So definitely new spillovers. So, but what it is telling us is that we definitely need to protect our frontline workers in those endemic areas, because this Bulape and in that Kaseya, this is the 7th time that they had these Ebola outbreaks. So we know in the country that we have the Equateur, we have Beni, and so on, that has been affected. So now the push is really to move forward preventive vaccination. And as mentioned, there are 500,000 doses of Ebola vaccine that are available at the ICG. DRC, the country has already established a plan to see how they can have those preventive vaccinations. Because if that happened, definitely the 4 healthcare workers who has passed away in the initial phase would have been protected. So I think this outbreak is an opportunity for DRC, but not only DRC, because we also have Angola, which is not far from that, and other surrounding countries. Congo is also preparing just in case. So those countries, we should also find the opportunity to support them, and that was a discussion that we have this morning with some of them to see how we can have that preventive Ebola vaccination. And as you rightly mentioned, Gabriel, so the virus can stay quite some months actually in the semen. So when we think about preventive vaccination, we think about the frontline workers, but also to people who will be living in the same area where we have some survivors. Thank you.
Thank you, Prof. We will switch to the chats and get some questions from there quickly. Let me take the first 2 relating to Mpox. The first one say, can you give us a clear understanding of a roadmap in integrating Mpox into the routine health services in member states? That's the first question. The next one says, what are I think you mentioned this, it will just be a repeat of some of the things you said on the slides already. What are the latest estimates of Mpox vaccine needs and availability in member states? Same questions for cholera vaccines as well. And what is the funding situation, requirement, and gaps to buy and deliver those vaccines? Over to you, Prof.
Okay, so I have my colleague, Dr. Mercy, who is online. So at some point, she can also come on the issue of the transition in countries. So in terms of vaccine availability, so as Mpox is concerned, we have estimated at IMST that we might need 6.4 million doses of vaccine to ensure that we protect we respond, we control the outbreak in the most of our affected member state. So far, we've managed to mobilize 6 million. 5 million doses have already been shipped to countries. So it is a bit particular. It's a large country. They've also, through the support of the Japanese government, to have 3 million doses that are in country, the LC16, while the other country has been benefiting from the MVAPN. So far, the countries that are really facing challenges have received dose of vaccine. Now, as I mentioned, the 3 countries that are of most concern as we do speak right now is Liberia, is Kenya, is Ghana, but also Guinea. Though the cases have a bit decreased, they were also increasing. And those ones have been supported by shipment of 20 to 30,000 doses of vaccine that they recently received. And those ones will be actually starting the vaccine soon. This is Guinea, but also Kenya has already used 10,000, and they will be receiving 20,000 so that they can boost the vaccination, especially in Nairobi, that is also now affected. But we are also looking at it on the side of the transition that you've mentioned. In the transition is the integration of vaccination into the API. So we see 2 categories of countries. We have countries where we are dealing only with, let's say, only with the outbreak, and we have those countries where that are endemic. So for those countries, we need to have the right estimate, which will move around 3 to 5 million of those of vaccine needed. So that what happened in the past for the smallpox, where we had those vaccinations to ensure that we eradicate smallpox, should also at some point happen for Mpox. So if we achieve that, we'll do 2 things. 1, we'll protect our people, but 2, we also accelerate the local manufacturing. Because to make sure that we have the local manufacturing in the continent, we need to have that demand, which is there. So we'll move forward to find the resources that you've mentioned at the global level, but also with the domestic financing. So as cholera is concerned, in our new plan, we aim to raise 10 million doses of vaccine. And in September, at the UN General Assembly, Gavi has already pledged the availability of those 10 million doses of vaccine. So as we move forward, we identify the top countries. We've mentioned them. We've mentioned Chad. We mentioned Burundi, who are currently the one having the surge. But we also have country like Angola. Unfortunately, Angola is not a country that is eligible for the support to Gavi. So for those countries, we have to think what is the best way to support them in terms of operational cost. They may have the vaccine, but if the funding are not available, it makes it difficult for them to respond. So on the side of the transition, my colleague, Dr. Mercy, is connected. Do you want to say something on that, Dr. Mercy?
Thank you so much, Prof, and good afternoon, colleagues. Thanks for that very insightful question. So on the side of the IMST, a number of actions have been taken to ensure that countries actually have this very seamless migration of the emergency system into the routine health structures. And one of the things that we have been doing is, first of all, as a continental coordination mechanism, to come together and actually come up with a roadmap for this transition, looking at the different pillars and really looking at how we can map them to the routine health systems. And that has been done. We came together during a workshop that lasted over 4 days thereabout to look at this plan alongside our member states and share with them this vision of transitioning, and that document has been developed and would be shared on our platforms in the coming weeks. The second thing that we've also urged countries to do is ensure that they also use this document to be able to come up with a national transition plan. And some countries have been doing already that. But what we really want to emphasize is really not having this end up in shelves, but really translating to the actual transition in implementation. And as you know, during the outbreak, we've been having very vertical systems like the vaccination system that has been there. We had logistic mechanisms that have been established, really vertical, but a surveillance where we had to deploy community health workers and been focusing strictly on the particular emergency of concern. But we know all these capacities that have been invested in countries need to really continue to strengthen the health system and also support not only the emergency that was used to mobilize these resources, but other emergencies and also routine issues in the country. So this plan is there, and we're hoping that countries will continue to domesticate this plan and implement as such. Over.
Thank you, Dr. Ken. Just before we go back to the section on raise hand, let's go back to our chat here. There are two other questions I will bring. This one is from Ayele Amebu. He is a journalist in Ethiopia. He says, what lessons has Africa's CDC learned from recent outbreaks, example, Ebola, COVID, Mpox, that are shaping the future response strategies? That's one. The next question comes from our colleague, Kemo Chen from Freetown Manual Reporters. Kemo say, what is driving up the cases in Liberia, and should the authorities be doing, and what should the authorities be doing now to halt the spread? I think is around the Mpox question. So those are two questions from Kemo and Ayele. Over to you, Prof.
Yes, thank you. So I will answer the question of Ayele, and Dr. Mercy, who was actually in Liberia supporting the country during the interaction review, will be happy to respond to the question on the driver of the increased number of cases. So what have we learned from these different outbreaks, COVID, Ebola, and now Mpox, is that we definitely needed a new model of responding to those outbreaks in the continent. And the incident management support team, this is co-led by Africa CDC and WHO, with all the different partners around, is definitely the model where we can see the efficiency, especially at the time where we have to do more with less. And this coordinated approach has significantly allowed us, one, to mobilize the fund to respond, two, also to mobilize the 6 million doses of vaccine, but also to ensure that we were moving as one team behind one plan with one budget and one M&E framework. I think that is a real change on the way we respond, to the extent that our head of state of the cholera-affected country have decided that we should use the same model for cholera. That's why in Lusaka in August, we actually launched the continental plan and integrated cholera within the IMST. So now we are in this new paradigm where Africa leads, and we have the multilateral organization that support in those key areas, which will include the training, the resource mobilization, so that we have all the tools and the resource that we need to respond. So that is one of the major lessons that we've learned. And then we'll be happy actually in Durban next week to highlight some of those key achievements and see how we move forward. Dr. Mercy, would you like to respond to the question on the interaction review in Liberia?
Thank you so much, Prof, and thanks for that question. So actually, last week or so, we were there with a team of experts to support the country in evaluating or assessing the response through the interaction review. And we saw a number of issues. Of course, this was more or less a conversation with the team on ground. They've done tremendous work to really curb the spread. But as initially highlighted by Prof, we realized that there were a number of key issues that, of course, we are supporting the country to look into. One of the issues that we saw was the issue around coordination. I think there's really some challenges with coordination in terms of national level and also at sub-national levels. Looking at it interagency coordination, as well as we saw issues around the different sectors really not well engaged. And these are some of the feedback that we provided, and we are supporting the country to look into that. The second issue that could also be resulting to the spread is the weak contact tracing that we saw. And this is because of the limited resources, financial resources to motivate community health workers to conduct active case, to conduct both active case search as well as contact tracing. So this is also an issue that it's been looked into and hoping that will be addressed. And also to highlight around the case management, most of the cases were being managed at home. So they were implementing the home-based care, which was also very, very difficult to monitor and keep the cases restricted from interacting with the population. So this also was one of the reasons why they continue to see high community transmission and an upsurge in cases. Then lastly, some of the key populations also, we found out that they had stigma around disclosing contacts. And so this was also very a critical issue that came up. And I think they are also improving on the risk communication and community engagement to be able to engage the community and break those stigmas so that cases can be identified in real time and addressed accordingly. So these are some of the key issues that I would like to bring out, and hoping that other partners that are listening can also join forces to support accordingly. Thank you.
Thank you, Dr. Ken. We now go to our colleagues who have raised hands. Let's take our colleague, Rachel Abuja from the Nigerian News Agency. Rachel, over to you.
Thank you very much, and good afternoon, Prof. and Dr. Mercy. Thank you for your robust presentation and explanation so far. Prof, given that the major drivers of cholera and Mpox outbreak, such as unsafe water, which you mentioned, weak surveillance, and humanitarian crisis remain consistent across countries, what practical step can government take to strengthen cross-sectoral collaboration and ensure that public health interventions go beyond medical response? Yes, you mentioned something around One Health and approach, but I think you just waived it, sort of. Then on vaccine, you mentioned several countries, have vaccines available, but lack the operational funds to deliver them. How critical is it for African government to establish domestic epidemic funds, and what model or mechanism would you recommend to make such funding sustainable? Please, I have a question for Dr. Mercy and you again. You spoke about the transmission of Mpox response activities into routine health system. How will African CDC support countries with weak health infrastructure to sustain vaccination surveillance beyond the emergency phase and also ensure that the lessons from COVID-19 and Ebola are not lost in the process? That's for Dr. Mercy. And for you, Prof, you spoke about the transmission of Mpox response activities into routine health system. How will African CDC, again, I take my question again. You mentioned that preventive Ebola vaccination is now a key priority, especially for frontline workers in endemic areas. Even reoccurring outbreak in regions like Kaseya, which you mentioned, what specific strategy is African CDC putting in place to ensure these preventive vaccines actually reach high-risk communities before the next outbreak occurs? Thank you so very much, Prof. And Dr. Mercy, thank you.
So that's a lot of questions. The other colleagues kindly gave our panelists the chance to respond to Rachel's question, then we'll come to you. Over to you, Prof.
Yes, no, thank you so much, Rachel, for the very pertinent question. And right, you are right. The driver are really far beyond the medical, the water, the humanitarian crisis, and even for the vaccination, the lack of operational funds. And the answer is the same. You know, Africa CDC, we support member states at three different levels. The first level is the political level. The second level is the strategic level, where we engage the Ministry of Health, we engage the National Public Health Institute, but also the operational level, where we support some of those institutions on how they can implement the actual response in the field through the guideline to some of the support that we provide. But for this specifical, it's at the highest level, at the political level. And that's why, as cholera is concerned, for example, we have the champions of AU champions, the president of Zambia, who is on top of supporting the resource mobilization for the response within the IMST, is also establishing the continental and the presidential task force at the national level. So ideally, each country that is affected by cholera will have its national cholera task force that is managed, that is led actually at the head of state level. That will ensure that you have all the different ministries, the ministry in charge of water, the ministry in charge of finance, the ministry in charge of planification, to ensure that the proper investment are in place to respond to these outbreaks. And also using the same model as you were talking about the One Health, to ensure that also the Ministry of Environment, the other ministry are all part of those task force, and to ensure that there is a comprehensive response. And by the time that you also involve the Ministry of Finance, then definitely you go into the domestic funding. And Africa CDC has shown as the example with the establishment of the Africa Epidemic Fund, which will help us to respond quickly before we even gather any support from any partners. So this is something that we will encourage countries, and to do it practically, we have started the recruitment of more than 15 collaborators that will go in countries supporting them on health financing to ensure that they have the capacity to mobilize those resources, to use them adequately, and also to be able to do the audit that we want, because we talk about domestic funding, but also we want to improve and to increase the transparency on how we use the fund. So for the preventive vaccination, and then Mercy will answer to the other question, there has been a gathering 2 weeks ago on preventive Ebola vaccination. So just to prepare the countries to do their plan, and DRC is really leading that process. They have a plan that is being finalized, so hopefully it will be finalized in the coming days or week, and then we'll find the way to support them. The vaccines are available. Some of the operation codes are also available. So once the country has the plan, I think they are targeting around 1.7 million of people to be targeted. Now we need to find out how efficient it will be, and therefore we can really support in the most critical hotspot, the most critical population, to ensure that this vaccination occur. We take advantage of this outbreak to ensure that preventive vaccination is implemented. And also in other countries, mention Angola, which is nearby, but also all other countries, West Africa, where they had an outbreak, Guinea, I think a year ago, also have an outbreak with few cases. All those countries should also have the ability to use that strategy. Over to you, Dr. Mercy.
Thank you, Prof. And thanks so much, Rachel, for those very great questions. To start with, there are a lot of lessons that have been learned. Lessons were learned during COVID, but the implementation, of course, we know was timid. But in the case of Mpox, we've picked specific issues, and you have highlighted a number of them. One is the weak multi-sectoral coordination, as well as issues around cross-border collaboration that were quite weak. And in terms of the integration, one of the things that we are supporting countries and really very intentional about is promoting the adoption of proactive surveillance mechanisms. And this includes event-based surveillance, includes supporting countries to adopt the One Health approach, ensuring that information is shared across sectors, so that if we are dealing maybe with a grade 1A, we are able to detect within the animal sector, the animal population, and able to prevent spillover to the human. So those are the kind of approaches that we want countries to adopt. Again, as you may have recalled, we've mentioned this severally on this platform, that we are working as Africa CDC for member states to achieve the 2 million community health workers target that has been set by the head of states by 2030. During this Mpox acute phase, we had deployed community health workers to support with community engagement and also promote adherence to some of our countermeasures like vaccine and all that. But again, these are just more or less some of the outbreak-specific interventions. We can't continue to rely on just sporadic deployments. So we are ensuring that we are really working to ensure that countries are able to sustain this workforce that we plan to ensure that they deploy. So we are looking at 2 million community health workers. And one of the things that we're doing is high-level advocacy for countries to adopt these healthcare workers and integrate them into their routine health systems, and so that they are able to continuously serve the communities and ensure that they are able to also support with other public health emergencies. Prof has mentioned the local manufacturing, but this is really critical, especially looking at some of the commodities that we have really rely extensively to, beyond the continent for procurement. And we are ensuring that as we continue to champion this local vaccine manufacturing and also local manufacturing for other countermeasures, we are able to bring capacity home and ensure countries are able to rely within to get some of these countermeasures at very cost-effective prices and sustainable pathways. Then just lastly, to mention that it's also important that we don't end without talking about public-private partnership. During this outbreak, we realized the really critical role that the public plays in outbreaks. I'll give you an example around internet coverage. We saw challenges in hard-to-reach areas in sending information real-time for action. And these are some of the things that we've taken into consideration and really fostering, not only through financial support, but of course, through these kind of mechanisms where public-private partnership can be leveraged for such services that facilitate information sharing. And beyond that, we're also looking at a partnership cross sectors. And that's why we're talking about the multi-sectorial partnership and collaboration. And in our routine health system strengthening initiatives, the One Health framework that has been developed and endorsed at the level of the AU is being used and really being so we're really using that and supporting countries to adopt this framework so that they can have such mechanisms in place to foster early detection as well as a collaborative response during health emergencies and beyond.
Yeah, thank you, Mercy. Just to add specifically, Rachel was asking an example of country in DSC currently, they are working on having 1 to 2% taxes on the tobacco and importation that can be used to actually populate the epidemic fund that they are working on. Over to you, Nick.
Thank you, Prof. Our time has almost elapsed, but our colleague Esther Nakazi has had her hand up for a while, so we're going to give her the opportunity to take the last set of questions for today. Esther, over to you.
Yeah, thank you very much, Prof, and thank you, Nick. I just wonder, I heard from WHO that the outbreak in DRC is using Starlink for their internet needs. And I was just inquiring, is this part of the partnership that has just been spoken of? Is it for free? Is it the first time this is being done? And how has it helped to get real-time data to improve the communication between the centers? The Starlink, did Elon Musk really donate it to you? Secondly, you've been talking about putting Mpox into routine vaccination. How feasible is that really? Really, how feasible is that? Thank you. And over to you.
Yes, thank you so much, Esther. I think definitely we could not end the session without having your question, and they are really critical. The first one is on the communication. I think this is a very good example. We take all those outbreaks as opportunities. Africa CDC has as rightly mentioned, has supported the response by providing those Starlink that were acquired, not the donated. Because what we've done during the Mpox was to use the DHES2 that was installed in the phone of the community healthcare workers, so that when they go in the field, they can use their phone, collect the data, and the data goes directly to the district, to the CUSP, and at all those levels. So in that Bulape, where there is no infrastructure, really the Starlink is a game changer on making sure that wherever the community care workers are in terms of the active surveillance, they can populate the data. And then by the time the colleagues are meeting at every day at 6, and really that is an intensive work that they've been doing in the field, they have the information on the contact, how they are follow up, and how they actually are. So that real information is definitely a game changer, because you imagine if at 6 p.m. you already know where you will be sending your team the following day, that definitely changed. And the fact that for the last 16 days, we've not had any one case, we also see that the contact ratio to case is quite high, 1 to 35. Those are some of the improvement that is definitely coming from these real-time surveillance. So I think that is definitely a legacy that is coming from Mpox, now moving to Ebola. And then the next step will be to scale that tracker and using that telecommunication Starlink as a real opportunity to move forward. And as Dr. Mercy was mentioning, we have 1 million community healthcare workers. We are moving toward 2 million. Just imagine if all those have their phone with the right connection, they can send data in a real time. Definitely, that's a game changer. So now you're asking how to integrate Mpox into the routine, how it is possible. This is part of the transition plan, and a guide means that at the end of the day, each country will find how it is feasible in their context, in their environment. You will not consider a country where Mpox is endemic as another country where it has been just epidemic. So they will decide. If I take DSD, as we just mentioned, they already have their plan. They know the region where they will need to target the population. So now, instead of having the vaccination in the reactive mode, then it will be within the API, and then they will decide. So every year, they will go and select the target population where they will be vaccinated, knowing that they will have a 5 to 10 year protection. In other countries, maybe they will say, okay, what we'll do, we will put it within the PEV, and then we will find when there is an alert, we go and we do a geographic vaccination where we can vaccinate an entire area. So different country, different reality. This is the beauty of having one continent of 54 or 55 member states. Over to you, Nick.
Thank you very much, Prof. Colleagues, we are 6 minutes over our time, so we're going to end here today. Thank you so much for your contribution as always. It has always been interactive. Thanks to Prof and Dr. Ken for the very responsive replies to your different questions. Just before I turn over to Prof to close out the section, I just want to re-emphasize some of our announcements. This week, as you heard from the beginning, the head of the IMST is in Dakar, Senegal, and representing Africa CDC, the Director General, at the regional immunization forum that is being under the patronage of the president of the country. And just to emphasize that there's lots and lots of information surrounding CPHIA 2025. Just go to the website, just Google CPHIA 2025. It takes you straight to the website. As journalists, you can have lots and lots of information about the program, the speakers, and everything that's going to be happening next week. With that, I will turn over to Prof for the closing of the session today. Over to you, Prof.
Yes, thank you so much, Nick. Thank you so much, Dr. Mercy. Hard thing definitely hard. And then we appreciate the support of all our collaborators, our colleagues who are working tirelessly in the field, in Bulape, in all those countries affected by Mpox, cholera, now Rift Valley, and all others. But also thank you to our leaders. I think moving from Berlin to Senegal to DC and so on within a week, and then ensuring that next week we are all together with all those our leader in Durban to ensure that we push the new public health order. I think it's important to appreciate. And of course, thank you to the journalists for making us accountable and ensure that you have the right information, that we have the right challenge, and then you can ensure that our community and our leaders are really following us. So with that, I wish you all a very good afternoon, and we look forward to have you next week at the same time from Durban. Thank you.
Recording stopped.